Hello, my name is Dr. David Flores, Assistant Professor here at the University of Texas Medical School in Houston, Department of Internal Medicine, Division of Geriatric and Palliative Care. Today, we're going to be discussing executive functioning and capacity in older adults. I'd like to acknowledge the VA Boston Research Team, the ABA Capacity Assessment Working Group for contributions to this presentation. Successful students will be able to discuss components that comprise an individual's executive functioning, list 4 conditions where subcortical brain changes lead to executive dysfunction, discuss the implications that memory, attention, language, and awareness have on an individual's capacity for self-care. And I'd like to start with a case study. This is the Possum House. One of the responsibilities that we have here at the University of Texas Medical School is that we assess individuals for capacity in the community. Adult Protective Services makes a referral and we send out a team to determine capacity. This is one example. We conducted a capacity assessment of this woman in her home. She was living in squalor and was a hoarder. This is a picture of one of these homes. You can clearly see animals. There was cats and dogs in the corner. Maybe a little hard to make out, but that's a parrot. And then there's a possum living in the kitchen. What's really interesting about this particular case is that the roof in the woman's bathroom had fallen through and a possum had crawled in through the hole and taken up residency in a grocery basket in the kitchen. Now, I mentioned that she was a hoarder, and as you can see, there are a lot of things in their kitchen, the kitchen floor. There were roaches, there was trash. And when we asked the woman if she would like us to call animal control to have the possum removed, she stated that she did not want to because it was too cold outside. So here you have a woman that is failing to recognize that her environment is becoming unmanageable, that she has a wild animal in her kitchen and she's not allowing us to have the animal removed. So she's failing to recognize the dangers of her environment, of having a wild animal living in her kitchen, and she's also failing to take the correct steps to resolve the problem. This is another view of her kitchen. There were ants, there were roaches throughout, there was animal feces throughout the home. And lastly, this is a picture of her living room, and you can see the corner of a mattress. There's a space heater there, and there's all this trash. When asked if she would like to have a major cleanup by Adult Protective Services, the woman stated she did not want to because she thought too many things would be thrown away that were too valuable. She then proceeded to pull up a receipt, old receipt, and said that she needed this particular receipt. So once again, she's failing to recognize the extent to which her environment has deteriorated, and she's failing to take the appropriate steps by accepting the help from APS, Adult Protective Services, to clean up. Here, this individual's capacity is now in question. I'd like to go to another case study. This is a case of medical self-neglect. This woman has something called ageria. It's basically colloidal silver supplement overdose. Now, this particular woman is, in essence, addicted to taking colloidal silver. And it's difficult to see in this particular slide, but you can see that her fingernails are black, her skin actually kind of glows, and basically her eyes, the whites of her eyes actually turn black, and we don't have a picture of that currently. This is where she's failing to understand that the colloidal silver is affecting her body in a negative manner, and she's failing once again to take appropriate steps to stop taking the silver. So how do we evaluate capacity in a manner that is both reliable and sound, or in other words, the agreement between raters and across time, and make sure that those assessments are valid and meaningful so that it gets to the real thing of that issue. It reflects accurate clinical or legal content, and it predicts those particular outcomes. And why is reliability and validity such a problem in capacity assessment? Well, discipline differences. A psychologist may view capacity different than a psychiatrist, that may view capacity different than an internist. There's a focus on different cognitive abilities. We rely on general impressions. And so there's a varying risk tolerance and values, and this may be affected by ageism. What is the underlying issue? Well, capacity is elusive. Capacity assessment is being applied to a new and more complex group of patients, and also a diverse group of patients, both ethnically and racially. Capacity judgments require positioning. So this is the dichotomous opinion about a continuous phenomenon, and clinical judgment balancing autonomy versus protection. This is a picture of what capacity continuum looks like. So at the top, where it's dark purple, this particular individual has capacity. And then at the very bottom, the individual where it's white lacks capacity. So in the middle, there's where the individual has a diminished capacity, but there's no solid break, there's no solid line, because this capacity, they may have capacity in certain domains and lack capacity in others, so it's fluid. This is another example. So there's an ethical balancing act. An individual has autonomy, or do they need protection? And then there's advocacy fidelity. So those individuals that have capacity have the right to live in the community independently, whereas somebody that lacks capacity may need protection, whether from their own selves, the environment, or other individuals, such as in cases of financial exploitation. So capacity as used in this talk, we have two. There's clinical capacity. A clinician provides an opinion about clinical capacity to function and or to make decisions within a specific domain that may be used as evidence, but does not alter legal status, although may result in a de facto loss of ability to make decisions. And then you have legal capacity. This is where a judge determines legal capacity, removing the rights of self-determination for a specific matter, altering the individual's legal status, and assigning the authority for the decision-making to another. What are these capacity domains? Well, you have financial. This is being able to manage your assets, bills, spending, making wills, contracts. There's healthcare, specific treatment decisions, advanced directives, managing meds, living independently, managing your home, managing your environment, making your meals, clothes, hygiene, communication. And then there are others, driving, relationships, research, voting, things along those lines. So what is executive function? Well, there's a cognitive process. It regulates an individual's ability to organize thoughts and activities, prioritize tasks, manage time efficiently, and make decisions. So here you have the executive functioning hub, and your frontal and temporal lobes of the brain are responsible for making all these decisions, such as organizing, speech, perception, cognition, things along these lines. Now this is another view of the brain. You have your prefrontal cortex. This is where judgment, decision making, and problem solving lie. Then you have your anterior cingulate cortex, which is where motivation, focus, and emotional reactions come from. You have the hippocampus, and this creates and files new memories. And then the amygdala, and this is where fear generates from. There's also concept formation, the formation of ideas. And this is the ability to generate ideas by using creativity, getting the facts, doing the research, having knowledge. All of these things are missing with executive dysfunction or somebody that lacks capacity. There's also self-monitoring. And this is the single most important mechanism in changing any thought or behavior. It allows one to uncover necessary changes and set realistic goals, and requires planning, motivation, and vigilance. In essence, self-monitoring is watching one's behavior, being responsive to the perception of others. Low self-monitor does not change behavior to meet situations, whereas high self-monitors Watch what and how they express themselves given the situation. So what are some conditions associated with executive dysfunction? Well, there's advanced Alzheimer's disease. And you can see here the difference between a normal brain, an early Alzheimer's patient, and then an advanced Alzheimer's disease patient. Alzheimer's, named after Dr. Louis Alzheimer's in 1906, when a woman who died presented with an unusual mental illness. In this instance, toxic changes in the brain may be taking place 10 to 20 years before the symptoms appear, distinguished by the formation of abnormal deposits of a protein, in essence forming amyloidic plaques, and this damage spreads to the hippocampus, which is the seat of memory. And then you have vascular dementia. This is the second most common type of dementia after Alzheimer's. And initial symptoms, there's an inability to plan steps needed to complete a task. Initially thought that vascular changes would rule out Alzheimer's, but later found out that more than one type of dementia can occur at the same time. This may be treated and resolved or partially resolved. There's late onset depression, and this differs from early onset depression in several ways. Typically, there's a less family history of depression in these cases, less impact of genes, more impact of dementia cognitive decline, and structural brain images vary substantially. So there's more vascular pathologies, more pronounced atrophy of the cortical and subcortical regions, and the white matter lesions are strongly correlated. And there's frontotemporal lobe dementia. These dementias also include primary progressive aphasia, Pick's disease, among others. And this is where nerve cells in the front and sides of the brain are affected. There might be difficulty in language, and it appears at younger age, roughly about 60. People survive for fewer years than Alzheimer's with this particular type. And there are other executive function conditions. Parkinson's disease. This is where clumps form deep in the brain. Lewy body dementia. More likely than Alzheimer's to have early sleep disturbances, well-formed visual hallucinations, and muscle rigidity. Creutzfeldt-Jacobs disease. It's rare, fatal, and it's a variant of the mad cow disease. Huntington's disease. Progressive and caused by a defective gene on chromosome 4. Normal pressure hydrocephalus. This is where there's a buildup of fluid in the brain. Wernicke-Korsakoff syndrome. Deficiencies in thiamine, common in alcohol use, brain injuries, and strokes. Executive dysfunction results in the inability to engage in the activities of daily living, a person's capacity for self-care and self-protection, and may affect the outcome in mood disorders, which may prevent the recovery of independence. And as we saw at the beginning of the presentation, the individual living in the home with the possum, this affects their shopping, their abilities to pay bills, driving, managing medications, managing their environment, managing themselves, and their safety. Executive function and mental capacity. So when an individual's mental capacity is called into question, the examiner screens for executive dysfunction. So capacity is the ability to perform mentally and the potential ability to hold the power to do something. This is communicating choices, understanding relevant information, appreciating the situation and its consequences, and manipulating information rationally. Decision-making capacity. So the legal definition, in essence, is a cluster of mental skills that people use in their everyday lives. This includes memory, logic, the ability to calculate, and the flexibility to turn one's attention from one task to another. Medical diagnosis. A physician can conduct an assessment of mental capacity. The courts typically decide, however, with the physician's assessment, they have a better idea of whether to determine whether a patient has capacity or not. So capacity for independence and safety, well, they require both decision-making capacity and executive capacity. In decision-making capacity, I have made a decision to do a particular task. And under executive capacity, that's the ability to execute a decision to do that task and then to carry out the decision. So what is the criterion for capacity? Well, there's memory, being able to recall certain facts that have been previously learned. There's attention. That's the mental concentration that you need to carry out particular tasks. Now, individuals that are dealing with executive dysfunction, you may find in their language aphasia, which is a difficulty expressing thoughts, maybe due to stroke or direct injury. Dysarthria, incoordination or weakness of speech muscles, slurred or difficult to understand. You may find voice problems, damage to the voice box, loudness, quality or pitch impairment, or other communication disorders, cognitive disorders, memory, concentration, or organization of thought. All these can affect language. Then you have awareness. And this in essence is knowledge gained through one's own perceptions or by means of information. In this particular picture, you have something called situational awareness. This hunter is very proud of his prize, but he is not situationally aware of the danger that's behind him, which is that cougar that's also eyeing his prize. So in essence, this individual is unaware of the situation. Then you need to have an appreciation for your circumstances. And that's more of an understanding of the consequences. And this is the ability to recognize and understand the meaning of, to know or grasp what is meant, comprehension, knowledge, discernment, and sympathetic awareness. And in many cases, individuals that lack capacity fail to appreciate their circumstances. Once again, going back to the case study that we saw at the beginning, the woman failed to appreciate the severity of the squalor in her home. She also failed to appreciate the dangers of having a wild animal in her home. This is a lack of appreciation. An individual may lack capacity in some areas, but not in others. For example, a person can live alone but may not be able to drive a car. A person may be able to take care of their home but not be able to take care of their finances. And there are many other ways where some individuals may have capacity in some domains but lack capacity in others. Competence. In this case, competence refers to a person's capacity to make a rational, informed decisions about his or her care or property. Medical competence denotes a person's ability to understand and make informed medical decisions. Competence is a legal term, and decision-making capacity is a medical term. In the second case study, where you saw the woman that was taking exorbitant amount of colloidal silver, she was lacking that medical competency to not take the silver. Diagnosis of a mental capacity. Well, you have the patient presentation, and then for the clinician, there's certain questions to consider. A comprehensive geriatric assessment is conducted, and then we assess those assessment outcomes, and then the physician or healthcare provider makes recommendations. This may start with a patient interview, and then interviews with significant others, friends, family. You conduct a comprehensive social history of the individual. Then there are comprehensive physical examinations, lab works, and other tests to rule out other causes. There are certain screening tools that can be used to assess capacity. As we mentioned, the physician's diagnosis or recommendations. And then it's best to have a multidisciplinary team meeting of social workers, physicians, nurse practitioners, other individuals involved in care of the patient. Then an intervention is developed to help provide the individual with the appropriate things that they need and appropriate resources. Finally, there's an evaluation, and then if there need be, we modify the intervention. So what are some screening tools for executive capacity and decision-making capacity? Well, we have the clock drawing test. This is where the individual is asked to draw a clock showing the time as 1:45 and set the hands and numbers so that a child can read them. For clocks 2, the clinician then draws another clock and the individual is asked to copy. Here we're looking for missing elements. More than one element missing typically indicates that there may be issues, or intruding of elements like words or letters indicates impairment. And here we have examples of abnormal clock drawing. The first clock is typically a normal clock. As you can see, it's round, all the numbers are present, and the hands read 1:45. This is typically seen as a normal clock. Then the second clock, you can see that the hands are skewed. They're not pointing to 1:45, they're pointing to different numbers. This is where the individual is unable to process 1:45. This is mild cognitive impairment. So the numbers are in error and the placement of the hands are incorrect. And then in the third clock, you have moderate cognitive impairment. This received a score of 4. And then in the fourth clock, you see severe cognitive impairment. This clock received a score of 2. As you can see, the clocks become less recognizable the more the impairment. We have the oral trail making test. This is where the individual counts from 1 to 25, then recites the letters of the alphabet. Then the individual is asked to pair numbers with letters. 1 to A, 2 to B, 3 to C, until 13 digits are reached. This requires the individual to keep the numbers and letters sequences in working memory. Then we have the St. Louis University Mental Status Exam, or SLUMS. In this test, the individual's attention, concentration, word fluidity are tested, among others. The Exit 25 interview. 25-item interview with patients asking them to perform tasks and respond to particular questions. Lower score typically indicates normal executive functioning, and this has been shown to have good validity and reliability. Examples of the Exit 25 exercise are stick out your tongue and say ah until I say stop. This tests their motor impersistence. Next would be, now listen carefully. I want you to do exactly what I say. This is their example of their echopraxia. And then there's word fluency. An example of this might be, I'm going to give you a letter. You'll have 1 minute to name as many words as you can think of with that letter. The letter is A. And then the individual proceeds to name as many words as they can with that letter. Other commonly used screening tools are the Coleman Evaluation of Living Scale, the Mini Mental Status Exam, and the Geriatric Depression Scale. What about interventions? It would be nice if we could just reach into the brain and assess and treat, but it's not always that simple. So some interventions. Some treat medical conditions such as depression or other psychiatric illnesses. Some treat comorbid illnesses or injuries or dementias. Counseling, if it's appropriate and the individual can participate in a counseling session, they have that capacity. Social support from family, friends, adult protective services, or other individuals involved. Social services, legal, law enforcement if necessary, and then follow-up and monitoring. And as I mentioned earlier, a multidisciplinary team approach works best. So for individuals that lack executive functioning and capacity, they may have poor to no medical care. They're more susceptible to elder abuse, self-neglect or neglect, financial exploitation. As you saw earlier with our case study, you have hoarding that may be of animals or other things. There's squalor in the home. You may find public health hazards, such as that heater that you saw in the living room. So there's fire safety code violations, etc. And all of these ultimately leave the individual more susceptible to death. So for the multidisciplinary team, you may have the patient or the caregiver at the center. You have psychiatrists, psychologists, nurses, nurse practitioners, social workers, case managers, and physicians, all working to provide the individual and their caregivers with resources and information regarding the condition and appropriate steps that can be taken. Then altogether, these individuals develop a plan of care and then initiate the intervention. This includes the medical team, social services, adult protective services. There may be legal and financial elements involved, the law if it needs to be, faith-based help, and other members in the community, all working to help the patient and the caregiver to provide a better quality of life. And it takes time and resources, but this can succeed. Here's an example of another individual that Adult Protective Services called for a multidisciplinary team to conduct an assessment of capacity. Here on the left, you see that exact same area as you do on the right. This is before the intervention and then after the intervention. You can see the home is orderly and clean. You can see in the left picture that there's a lot of squalor. You can see that there's a lot of items, and in the right you can see where those have been removed. This is another example of before and after. On the left you see the bedroom, the bed. There's multiple things there. There's clothes, there's clutter. And on the right you see the clean, orderly bedroom. And in the lower area you see the dining room. And once again, marked by clutter and dirty items. And in the right, you see those things clean. So, in short, what I'd like to say is that the multidisciplinary approach works for assessing capacity and provides the individuals involved with a better quality of life for both the patient and their caregiver. Thank you very much.